Good morning and evening, wherever you are in the world, and welcome to the Bonnie J. Addario Lung Cancer Living Room and Patient Educational Series. I'm Bonnie, and thank you for joining us. From our living room to yours. We are all living with lung cancer, and our goal is to bring hope into your home. Empowered patients live longer, and our message is simple. We want you to live.
Hi, everybody. Welcome back to the Lung Cancer Living Room. We're so excited that all of you could be here in the room tonight. Some people are still filtering in. A huge thank you to all of you out there signing in via Ustream. I want to do a quick shout out to those of you who are signing in tonight. You can either just click on the link and watch what's happening here, but if you'd actually like to participate and ask questions of Dr. Oxnard, you need to click the little sign-in button in the top and create a username. As most of you know, I sent out reminders and emails and Facebook posts and all kinds of good stuff about our guest speaker tonight, Dr. Geoffrey Oxnard from Dana-Farber. He flew all the way out here from Boston, and we cannot thank him enough for coming and being a part of this tonight, letting you guys know all about some really great things that are going on. But we're going to go ahead and start with our Around the Room first. So this is always like, everybody's always like, don't start with me. Elaine, do you want to start tonight? We'll go this way. I think last month we went this way.
Hi, everyone. My name's Elaine, and I was diagnosed with BAC. I still can't really pronounce the name of the real one, but I let her do it because she does it really well. Anyway, I have been off chemo now for a number of weeks, which is wonderful. It's very slow growing, according to Dr. Dormady, and I certainly trust him. And I was just worn out. I took chemo for 4.5 years. I had very little time where I didn't take it, and I tried everything from Tarceva to Gemzar to whatever, and it was really well worth it because it didn't grow very fast. And I had some shrinkage, but I don't think I have the kind of cancer that's ever going to go in remission. But who knows? Things happen all the time. So I have high hopes, and my hair is growing. And as I told my friends over here, it's sort of an Anderson Cooper style, you know. I don't have his good looks, but I certainly have his hair. So it's all worth it. It's just coming in very slowly, but at least I have some. So anyway, so happy to be here tonight and to listen to you, and thank you very much.
Hi, I'm Sally, and I was caught early and was 1A. And adenocarcinoma, I never can say it right even after all this time. So all I needed was surgery, and thus far it's been 4 years, and I'm still clean.
I'm Esty, and I had stage 1 bronchoalveolar, and I had surgery, and then I had a few years, it's been 9 years. I had a few spots a few years later, and they're monitoring them every year. And so far, I have to do a CT in April again, once a year. Okay.
Thank you, Esty.
I think they have their own.
They've got their mic.
Thanks.
Is this working? Oh, yes. My name's Tina, and I was diagnosed in November of 2010 with stage 3B. Non-small cell adenocarcinoma. And I was tested right away, and so I had the EGFR, so I was lucky about that. But I did do chemo and radiation, and then after I had a clean scan after that, then I started on Tarceva, and I've been on Tarceva since then, and so far so good. All my scans have been clean, so I'm feeling good.
And the guy to your right.
Who's that guy sitting next to you?
What, this one?
Yeah, that one. Yeah.
I'm her husband.
I should say caregiver.
Right.
She doesn't need much care.
Hi, I'm Mary, and I was diagnosed with stage 4 adenocarcinoma, non-small cell lung cancer, in October of 2010, and I went immediately on carboplatin, Alimta, and Avastin, and I had 13 rounds of that. And originally, I had a tumor in my lung, and then it had metastasized to my spine. And since I did that chemo, the spine has not lit up. Nothing's lit up outside, so that's encouraging. And then I went. I had radiation, target radiation, on my spine and my lung in November of 2011. And then I went 10 months without having any treatment, which was amazing. I just felt like normal, completely. And then I developed a new tumor next to the original tumor, and I started on Tarceva in last October 14th. And so far, I'm stable and really encouraged. And I'm very glad to be here at Bonnie Addario. These are wonderful people doing a great job.
I'm the husband, not the caregiver.
My name's Elizabeth Lacasia. It took a while for me to be diagnosed, and when I finally was diagnosed in 2007, I had bronchoalveolar carcinoma with a mixed with a papillary. I originally had a lower left lobe removed, as the tumor, there were a few tumors, but the largest tumor was the size of a ping pong ball. I was told at that time that I was cured. About 12 months later, it had spread throughout my lungs, and I had a wedge resection done at that time to confirm that it was reoccurrence. And then I went on my first round of chemotherapy, which was a combination of Gemzar, carboplatin, and Avastin. And then they had kind of a maintenance on Avastin. And I responded okay, not great, and that held it somewhat for about a year, and then I progressed. And at that time, I had a second, before that time, while I was still undergoing therapy, I had molecular and genetic testing done under advisement from my secondary oncologist, who now is my primary and wonderful oncologist up at UC Davis. And that testing basically showed that if I had had the molecular and genetic testing done prior to the first round of chemo, that the regimen would have been different, because one of the most toxic chemos my tumor was resistant to. So even though I'm wild type, which essentially shows that they don't have a lot of information on it, there still was more information as to what might work. And so when I progressed again and metastasized, because I'm stage 4 metastatic lung cancer, I went up to UC Davis, and I'm now participating in another clinical trial that combines Alimta and Tarceva. And I'm on my 52nd round at this point. After a while, I did go off the Alimta because we started kind of having some probably toxicities. After a while, my creatinine, which is a measure of liver function, started increasing, and the side effects, the intestinal issues, and just, edema, the whole 9 yards. You could just kind of see that my body was like whacking out. And so they decided, Dr. Gandara said, we'll take a risk. I'm not sure which one's working here, but I think it's probably the Alimta that's causing the issues with the the kidneys, and so he took me off of that, and it's been about, I think, around 26 rounds that I've been off the Alimta, and I just had my CT scan. I'm considered stable. I've had a complete response. There's one little spot that's, maybe kind of going on. We're not quite sure, so we're just going to kind of keep an eye on it and watch and wait. But, so far so good. I'm doing really well, and thank God for Dr. Gandera and his depth of knowledge. I really believe that because of him I'm here today, and really glad that I found Bonnie and the Bonnie J. Addario Lung Cancer Foundation, because I just think that this forum is just such a wonderful way to be able to share information and learn from each other. So it's just a great place to be, and really glad that you're here to talk to us and tell us more about our disease.
David.
My name is Dave Palomares, and I was diagnosed with mesothelioma in January 2009. And I had an extra pleural pneumonectomy performed in March of 2009, which is just an elegant way of saying I had my right lung removed. And then I received 4 cycles of chemotherapy, including cisplatin and Alimta, and then followed with 30 days of radiation. And so all my treatments were completed by October of that year. And CT scans, I get them about every year now. I'm on the annual test cycle, and they've all been clean so far. So I'm doing pretty well. And while we're talking about our caregivers, I'd like to give a shout out to mine, because I think they're the best. They're my heroes, and I couldn't have done it without them.
Hi, I'm Nancy, and I guess my story is a little bit different. My mom should be online watching as well, and that ties into my story. Kind of in brief, she had breast cancer twice, and in 2000 they found spots in her lungs, and they assumed it was she had stage 4 breast cancer the second time, so they assumed it was the metastasized breast cancer there, and they were too small to biopsy. And she was taking a drug called Farber, and kept those at bay for a long time, until about this time last year, the regular scan showed one or two of them had grown, and so she had a biopsy. She's in Alabama, and a second opinion was done at Vanderbilt University, and luckily for us, Dr. Carbone was there. And he did this test on the gene mutation, and they found that she had it and recommended her, family ties would get tested. And so I went to Stanford and the gene department and said, my mom has this. I need to find out. I have a 50-50 chance. And like Dr. Carbone and my mom said, they would push back and say, wait a minute, that usually shows up if you've been taking Tarceva. I go, they told me you would say that. No, it's different, And then I met them, and we got the test done, and unfortunately I showed up in September as positive for having the gene mutation.
What was the gene mutation?
I think it's the EGFR.
T790.
T790, thank you. See, I don't have all this down like you guys do. This is very new. And so, no, it's new. What's the protocol? They said, let's get a baseline scan, and they also have my breast exams more often now, twice a year. And so I had my baseline scan in November, and it wasn't just a baseline. There were some spots on there, about 11, and one of them was about the size of my fingernail, so that's the suspicious one. I had a wedge resection in January to remove that, and at that time it was found to be precancerous. And my next step is to have another scan in July to keep an eye on the small ones. But I'm blessed that Dr. Carbone found that in my mom, because I would have never had a chest scan. I didn't have a reason. So anyway, I'm glad to be here and looking forward to the discussion.
Thank you. My name is Sandy, and I was diagnosed with lung cancer August of 2012, and I have the ALK positive gene mutated. They immediately put me on Xalkori, which I seem to be responding to very well. They just keep saying everything's shrinking and going away. And I have to say, it's only been 2.5 weeks that I think I have really faced what is in my body. And it started with my standing up in front of a volunteer group that I work with. And I decided that I needed to acknowledge this. I needed people to know what was going on, why I was gone so much, what my life was now. And I stood up and told everybody, as much as I could, for not being a doctor and just beginning to really acknowledge what it is my path is going to be. So by next time I see you, I will have some of the verbiage. I'm writing things down as people speak because I want to understand this, especially from what I get that my doctors are telling me is, you know, this is a new frontier. It's hope. These genetic studies, we're really being given a chance, and I want to be a part of it.
I'm Renee. I'm just Sandy's support person.
Okay, so I'm new to this too. My name is Donnie, and my mom was diagnosed with lung cancer back in October 2012 with stage 1B. She's also in Alabama, and I'm here because I met Danielle a while back and just interested to learn more about what's going on within the lung cancer world.
Hi, I'm Jennifer. Over this past Christmas, my husband Harlan found a lump on my neck, and in first week of January, I was diagnosed with stage 3B lung cancer that had metastasized. I do have the EGFR mutation. I've been on, just finished today, a 7.5-week course of treatment that was radiation every day and 2 rounds of chemo, including cisplatin and etoposide. So now we wait a month and do the next PET scan, and the likely next step is Tarceva, so I'd love to talk to you ladies about that. And that's where we are. We're thrilled to be here tonight.
Or Jeff.
Or Jeff.
Yeah, he'll tell you.
I'm Jennifer's husband, Harlan.
Hi, I'm Henry Herringsma. I do lung cancer research for a biotech in San Francisco, and I just find these patient stories very inspirational. Thanks.
Hi, I'm Neil. I was diagnosed almost 2 years ago with stage 4. It was a pretty short process from visiting the doctor, my internist pulmonologist who suspected something after the little cough that wouldn't go away, to a chest x-ray, CT, a biopsy in the space of about 4 or 5 weeks for the whole thing, to a diagnosis of stage 4 adenocarcinoma, EGFR mutation, etc. Shortly thereafter, I was prescribed Tarceva, and very shortly thereafter had a very positive result from it. Tarceva to me was like giving speed to somebody with ADHD. And for 13 months, it was wonderful to be on it. Amazingly enough, it did everything it possibly could want to and even more. But like for so many people, mutations come up, the cancer's smart, gets around it, started to not work quite as well, so made a change, not that I wanted to necessarily, but made a change to IV chemo for about 5 months, and that was terrible. Being on that, really did not enjoy that part whatsoever. All the blood levels go down. Energy level, still okay, could bike ride, but everything, even a flat road became a hill to me, so I wasn't enjoying that as much. Beginning of January, I had the opportunity to participate in a clinical trial that one of our guests here, Henry, who mentioned that he's working on a drug program. It's Clovis Oncology, and I started that, showed results within 1 day. I could see a difference. I've been on it since January 7th. Have had one CT done in that time with another one scheduled next week, and have showed shrinkage in that area. And this drug is hopefully the one to be the next generation, similar to but even better than Tarceva. In addition to having the EGFR mutation, as part of the trial, I had to have another biopsy, and that showed that the mutation had the cancer had mutated from the EGFR, and also showed some T790M, which is seen in approximately half the people who have EGFR. That's what happens. So I'm one of them. So little by little, it's subsecting its way down. So eventually, whatever treatment there will be just for me. And that's what I'm hoping Henry will continue to work on, and all of the other doctors and researchers will find the one for me, and the one for Elizabeth, and the one for each and every one of us here and watching online, because it seems to me that really is the goal. I've always thought if there's some way you could take out my immune system and jack it up and put it back in me, that would really help also. I could fight it, by myself somehow and do that. But that may be a few years out in the future.
They're working on that.
Yeah.
I understand, and I will encourage everybody to, at least if you have not yet done so, at least consider a clinical trial when the opportunity arises. Do your research on it, find out if you think it's appropriate, ask the questions, because as I understand it, approximately 4% of the people who have lung cancer or have cancer in general participate at some time in clinical trials. That means there's a lot of us who don't. And to get the next Tarceva or the next Afatinib or any of the other drugs out there, it will take us, our bodies, so we can help the next person, whoever gets it. Thank you.
And Neil, thank you for the new tagline. We're going to use it, just for me.
Just for me.
Yeah, we're going to use that.
I wanted to ask Jeff if he recognized the accent at all.
Right.
We talked about
where Neil might be from.
I'm Penelope, and I'm here for my mom. She was diagnosed last February, stage 4 non-small cell. She started on Tarceva. After about 5 or 6 months, she was no longer getting a response. So she went to chemo, Alimta, Avastin, I think. I don't know. It's a combination of 3. I can't remember now. She had 6 rounds of that, and then just had a scan at the end of last week. Things are stable. Getting smaller, so they're going to take a shot at some radiation. So we're going to, hopefully the next week or 2, start just the traditional radiation. I guess it's the rapid arc. And it'll probably go on every day for about 7 weeks. And along with that, she'll do Taxotere IV chemo once a week. So if anyone has any thoughts on that, I'd love to hear about that. She's feeling well overall, and so we're just trucking along. And then for the new people out there, I found this organization a year ago now. Last March was the first time I came, and you guys are in the right place. You'll find out a lot of information and get a lot of good connections. So you're in very good hands.
But what's the most exciting thing happening to your mom very shortly?
She's getting 2 new grandbabies. Not only one from me. My little sisters due a week before me, so this will be 9 grandkids for them. So, in about 10 more weeks.
Thank you. Well, I'm one of those new people, and my name is Chrissy Flosoris, and this is my husband, Chris. And I was diagnosed in October 2012 with stage 4 non-small cell lung cancer, squamous cell carcinoma. And I am about 5 months into it now, and I have been on Tarceva right off the bat. And I had my second PET scan just about a week ago, and it turned out to be substantially improved. So we're in the beginning stages of this. So we're here to gather information. We're here to find out what the next plan B could be for me, whether it be radiation, whether it be surgery, or whatever it is, a clinical trial, new drugs. And in my case, I did have I have a 9 centimeter mass in my upper right lobe, and had metastasis to my spine and my left lung and also my brain. And I had 2 gamma knife procedures, the last one on February 28th. So things look really well right now, and we're very optimistic, and like everybody here, very, very happy to have found you in the Lung Cancer Living Room, because when we were researching, this was the only place where we saw positive information, the hope, encouragement. Everywhere else you research, you don't see that. So we're very thankful to have come across you, and we're hoping for the best, like all you. So thank you.
I have a question for you, though. Your squamous cell, and you were EGFR positive.
Yes, I'm sorry. Yes, I was. I was EGFR positive.
Yeah, that's
and
interesting.
I was tested for 2 genetic mutations for which for which targeted therapies have been developed, and I just so happened to be fortunate and blessed to have had that EGFR mutation. So that's why I'm responding so well to Tarceva, and I guess that's pretty much where we're at.
To editorialize, I think you actually have adenocarcinoma.
You think
and
so?
when we did the biopsy, it just looked like squamous cell carcinoma on the biopsy.
That's another thing. You know, we did send our pathology to Stanford, and I to their pathology department.
But it still may look like squamous cell carcinoma. But there's described cases where you take a biopsy, and the small biopsy shows squamous cell carcinoma. But if you took the tumor out and cut it up, it would be a mixture of adenocarcinoma and squamous cell carcinoma, as in fact an underlying adenocarcinoma biology. It doesn't matter that much. Your cancer is defined by its EGFR mutation.
Right.
But I would think of you more as having an EGFR mutant lung cancer than having a squamous cell carcinoma, because it does impact the treatments down the line.
Right.
And I would try to not classify your cancer as squamous cell carcinoma.
Right. I just mentioned that.
No, I say that because of clinical trials. I say it because, in fact, it matters how we classify our cancers, because the way clinical trials work is it's taking people who fit in a box and trying to say, I'm going to study people like this. And in many ways, you want to make your case conform to some other cases so that you can all be studied as a group.
Right.
Every person for themselves is great conceptually. We'd love to treat everyone individually, but we have to study people as groups. We have to fit them all together into a community to study them as a group, and that's how we learn things. And we'll talk about that a little more, so we can talk more.
And that's why information is power.
Right.
Information is very powerful.
Definitely.
Because qualifying for clinical trials is very helpful to all the patients out there, and the more information you have, the better trial you will be on.
I'm Jim, and my wife is Nita, is down doing what she loves the most, and that is to take care of grandchildren. And she's watching right now as we're here. So a shout out to my lovely wife, and I miss you, and I'll pass it on.
Is she online?
Yes. Oh, yeah. She's online.
Okay.
Yeah.
Okay. Shout out.
She'll be glad to hear that from you.
We miss her.
I think. I think the back row's good.
Diem never wants to talk, but it's so good to see you. And Linda, you need to know this, Jeff, travels here from San Diego once a month.
Fantastic. Who's Linda?
Linda is on the right.
Hi, Linda.
I wasn't going to, but thank you. Yes, I do come from San Diego once a month. As long as my little car runs up here, I'll come. This is the best place to be. Our daughter was diagnosed with stage 4 lung cancer November of 2009, and she's been through intravenous chemo, and lately now she's been on the Tarceva, but she had some trouble with another chemo they gave her. I can't even remember the name of it, so they took her off that. So now her next scan is April Fool's Day, so we'll see what that does. Anyway, this is the best place, and you new people that are just starting to come, you're lucky you found this spot. Our son lived in San Francisco at the time, and he found this place. And he said, Mom, you got to come up for this meeting. And it's really worth it. Great information, great support. Everything new that comes down, I don't need to research it on the computer. I know that it'll be here, or if I don't make it to the meeting, I just call Danielle and she keeps us all updated. So congratulations to all of you who've just found this place. It's worth coming to. So thank you.
Anyone? We're good? Terry's about to join us, so we'll...
Oh, here comes Terry.
Grab
Jude.
Terry, you're just in time.
Terry.
Late Terry.
You're the last one. It's perfect timing.
Good timing.
And oh, by the way, you're coming later and later. Okay,
I know.
Yeah.
The only thing that I really want to say is that Natalie is doing well. She caught a cold today, but she actually celebrated. Yesterday was her 3rd year anniversary from being diagnosed. And she also, as of the February 25th, the decision to stop chemo so that she can, it was a good decision. It was a fork in the road, but we've been working towards this decision for a while. She needs to find out whether her body is keeping the cancer under control, or, she was feeling that the chemo might be poisoning, doing more damage to her body than she feels that her immune system is helping to keeping the cancer under control. So she needs to find out what her body is doing, and whether the cancer, the one spot that was being stubborn, that was radiated, was the main source, and that maybe the chemo wasn't needed. But she always has plan B and plan C. She can always go on. She has the Ross one, and so she can go on those several drugs that are in the process there, and then she can always go back to Alimta. She's got several options, so if it does come back.
And she just got back from Disneyland, didn't she?
Yeah.
No.
Was that a while ago?
That was, yeah, somebody else.
Oh, Brian just went.
This is a family member of yours? I'm sorry.
Her daughter.
Sorry?
Your daughter.
Her daughter.
Okay.
My daughter, yeah. She was diagnosed when she was 32, non-smoker. Took them about 6 months to diagnose her. She's got 2 little girls. Megan just turned 4 on the 15th. And so, but she was stage 4, and she was still on her first, she started out with the 3, Alimta, Avastin, and Carbo, and then she went down to Alimta, Avastin, then dropped Avastin, and then she's been on Alimta for about a year now by itself. But it's been stable for 3 years. She's never. So she actually went back. She saw Dr. Swanson. Mm-hmm. They were going to do a EPP. Mm-hmm. Yeah, but when she went back there to get her lymph nodes tested, they were positive, so that squashed the operation. But we've seen Dr. Swanson back at Dana-Farber.
Hope I get to meet her sometime.
Yeah. Oh, you will.
Okay.
You will. You can see we have some really, really smart patients. You can't fool them. So I don't want to intimidate you here, Jeff, but.
Online, and Ben's mother-in-law, so Miles' mom, is online. And this is a question she wants me to ask Dr. Oxnard. So we'll wait till we get to that point, but tell her hello and to give Emily big hugs for us.
Okay.
As you guys, most of you know, Emily Taylor, she was diagnosed at 28. She just recently had surgery out in New York, and she's doing really well. She's recovering nicely in New York. If you don't follow her blog, Miles et al., her friends keep up with it and let you know daily through photographs and really beautiful words how Emily's doing. So it's a really inspirational blog to follow.
For any of you that were at our run, our 5K run in San Francisco in September, Emily brought, 140 close friends from Los Angeles up for the run. So there's Team MBen out there that is really, really powerful.
They're great. They're great.
Hi, Mom.
So with that, I am going to switch gears here over to Dr. Oxnard.
Can I introduce myself?
Yeah.
Yes, you may.
Absolutely.
Please do. He's mic'd. He's mic'd. Yes, go.
I'm Jeff Oxnard. I'm an oncologist at Dana-Farber in Boston. And some people don't know what Dana-Farber is. This is a cancer center associated with the Brigham and Women's Hospital and with Harvard Medical School. I'm from New England. I grew up on a farm in New Hampshire, raising horses. And I trained in various places in Chicago and New York. Lived in England for a bit, lived in LA for a bit. I think I've learned from my travels all over the place. I'm not just a guy who's been at Harvard for 15 years. And I am both an oncologist, I take care of lung cancer patients, and I'm a researcher at the same time. And I think I need to say thank you all for coming and for sharing your stories. It's really amazing hearing all your stories. And I wish I could have 60-minute consultation with each individual one of you, which is because of I really like caring for patients. It's amazingly powerful to speak to people about what they've been through and to try to share advice. It's, people working at a place like Harvard, I sometimes meet people once for 60 minutes. They come in and I get to see them once. And it's like, wow, what can I tell this person in just 60 minutes to make an impact on their living with lung cancer? And what, during that same time, can I learn from them? And that's how what I do as an oncologist influences me as a researcher, which is that every person that I care for is a lesson. And to some extent, it is an experiment in of themselves. And it's the patients I care for that I develop my ideas from and that I develop hypotheses from. And then those questions I test in my clinical research. So I'm both a researcher and a doctor, and it's all meshed in together. And thank you all for being here. That's my introduction.
I love your introduction. So as you all know, one of the things that I asked Dr. Oxnard to talk about today are clinical trials. I know we all kind of have a general understanding, and we've talked about it in bits and pieces with some of the other speakers that we've had, but to get a good overall understanding about what they are, what they mean to you, what they mean to discovery, when the appropriate times, so on and so forth. So we're just going to start off with a question to Dr. Oxnard about how important are clinical trials for not only patients, but for purposes of discovery. So it's kind of a two-part question.
Mm-hmm. Clinical trials are how we ask questions. My handwriting's terrible, but I'm speaking as well, so. And are how we answer questions. That's the key to clinical trials. I'm going to answer your question with an anecdote. When I was in training, I was studying the T790M mutation, which is this resistance mutation that occurs in EGFR mutant lung cancer after being on Tarceva for some time. About half of patients, as we've heard, acquire T790M. And what I was doing was working with some labs to try to understand how those cancers that acquire T790M behave. Just like the Clovis folks do in many labs around the country. And one of the interesting observations coming out of the lab of William Powell, now at Vanderbilt, was that these cells that acquired T790M seem to have a slow growth, that they grow more slowly in the resistant setting than they used to grow before they were resistant. That's sort of interesting. Okay, we think we see a slow behavior to T790M. And I was sitting at a conference and I heard this described in these cells, and I was like, that's interesting. All right, I'm going to try to take that science and turn to my patients in clinic and say, can I learn that from clinic as well? And what do you know, a few months later, I saw a patient who had T790M in her cancer, and I said, oh, this is great. Here we go. Does this person have slow growth? And she had been diagnosed with lung cancer 4 years earlier and had multiple spots in the lungs, consistent with metastatic lung cancer, and had a biopsy, and an EGFR mutation was found. And that EGFR mutation was not T790M, it was an X19 deletion. And I said, wait a sec, she's been off treatment for 4 years, hanging out with metastatic lung cancer. That's weird. Why is she growing so slowly? I bet she's got T790M. And so I went back and tested the tumor again and found T790M in the tumor. I ask questions. I learn from the science that I'm seeing in the lab. I see a patient. I ask questions about a patient. Every patient's their own experiment. Look at that. Asked a question and answered it on a single person. This person has T790M. That's neat. I'm seeing in clinic what I also see in cells. And the second question is, why is her cancer growing so slowly? 4 years, no treatment, hanging out, barely growing at all. That's weird. And one thing that had been described a few years before is what Nancy spoke about earlier, which is T790M in patients' blood, in their own familial genes. And this can be associated with inherited lung cancer in families. And what I said is, wait a second, maybe the reason her cancer is growing so slowly is because T790M is not just in her cancer, but it's in her family genes as well, and therefore it explains this sort of entire biology of her cancer. Her cancer is very dependent upon this slow-growing T790M. So I tested her blood, and it was in her blood as well. Wow. So I've had one person where I've now used my hypotheses, my questions, to ask how their cancer behaves, and to learn that this person has T790M in their body, in their genes. What does it mean? That's interesting. That one case is interesting. But it doesn't tell the whole story. It's not convincing when it's just one person. This is what clinical trials are. This is why we do research. We do research to ask questions about a community of people. If you want to answer, is T790M associated with slow growth? Or is, when you see T790M in a lung cancer at diagnosis, does it mean it's in their familial genes? What you have to do is get a collection of patients. Right? You have to get 30 people. I want to get 30 people who have T790M in their cancer and find out if I test their familial genes, their blood, is it in their blood as well? And what that is a clinical trial. Right? It's a certain kind of clinical trial. It's a sort of a biomarker analysis. There's no treatment involved. I'm just taking patients. They fit my criteria. They fit in the box I'm interested in studying. And I'm saying, I want to ask, can I show that it's in their genes because it's in their cancer? Their cancer's genes, which are normally different, right? And people are here wondering what I'm saying. I'm going to now explain T790M. That's this mutation we're talking about. And so to do that, and as a clinical trial, I have to ask it on a number of patients. And that's how we answer questions in a rigorous way. If I tell another doctor, guess this cool case I saw, he's going to say, you know, it's just one case. But if I say, I studied 30 people, I asked a question, I answered the question in a rigorous fashion, that's a clinical trial. So the clinical trials are how we move the field forward in a rigorous way without just learning from one person here and there, but by collecting people together. Does that answer your question, sort of?
No, I think
yes.
So, but biomarker analyses are not the most important part, right? It's treatment trials that are more important. So treatments are another type of clinical trial. In biomarker analyses, you're just submitting your tissue and saying, hey, learn from me. As a therapeutic trial, what you're saying is, look, I'm going to collect together 30 people who have a certain type of cancer. I'm going to study them as a group. And that's how new drugs develop. Look, I think the Clovis drug is probably pretty cool. It does a lot of great stuff in cell lines. But if we're going to show that it works, we need to collect together a collection of patients who all fit certain criteria and study them as a group to say, does it really live up to our expectations? And that's how we ask and answer questions. And that's why we put you guys through all these clinical trials, the paperwork and the consent forms and all the studies. It's to answer questions in a rigorous and reliable way.
So that brings up a question. I'm sure. If you guys have questions as we're going along, questions, please just raise a mic. But to that point, when we're talking about, this kind of goes into the next thing about the different types of clinical trials, and you already did the biomarker analysis and the therapeutic. What about like supportive care trials? I mean, there's so many different types out there, and I think one of the things that's hard for patients to understand, and talking with them every day, is the differences in them. Can you be in one more than one at the same time? If you could talk a little bit about that.
So I will say that everyone in this room should be on some kind of a tissue analysis study. Why not? Your tissue's hanging out in a refrigerator somewhere. Your blood is a reusable resource. Sign on the dotted line. Donate effectively what's happening to you for the rest of us to learn from. There's no reason to not do that, really. I mean, hypothetically, if you have a very small biopsy, you want to be conscientious over how it's used. It could be used up. But if you've had a lung surgery, sign up for some correlative analysis. All the patients at Dana-Farber get signed up for a biomarker analysis, where we now have a database of 2,000 patients that we've been studying over the past 10 years. And that's how we learn from them. I recently wrote a paper about a collection of 30 of them that had one relatively uncommon EGFR mutation called exon 20 insertions. And I did that because we've been collecting their information for a decade or longer. And so I was able to find 30 patients in this long history of patients that all fit a certain characteristic. And I told a story about them and compared them to the other thousands of people in that group. And so there's no downside to signing up for a tissue analysis study. And sometimes you can sign up for a lot of them. The limitation is how much tumor tissue do you have. But generally, whatever cancer center you're at, it's fine to say, sign me up, let me join in. And that's partly because all of you should be having your tumors tested. No question, your tumors should be tested for EGFR and for ALK. And if you need a way to do that, come to an ALCMI institution and sign up for the CASTLE study, which is the study we're now doing to do biomarker analysis in a rigorous way on all lung cancer patients who are available and who consent. Again, just to collect a community of patients to study. That's different than treatment trials. It's a little hard to be on more than one treatment trial at the same time. I'm going to rip this down and move on. The main types of treatment trials are phase 1 studies, phase 2, and phase 3. You also spoke about supportive care studies. And I will say that they don't fit this exactly. It's a little bit, but if it's an interventional study, if it's adding a new supportive care to your treatment, it's hard to be on that study and some other treatment trial as well, right? Because effectively what we're doing is you're testing in a group of 30 patients or more how a certain intervention works. The way these work, and you guys may know this, but you may not, and just because people talk about this a lot, I want to walk through it. Phase 1 studies primarily test toxicity. Phase 1 trials are the earliest trials. The first time a drug is getting into patients. You're probably on a phase 1 trial, I'd expect. Right? So not a lot of patients have been on this drug yet. We don't quite know what it does to people. We don't quite know if some weird side effect will happen. There's some risk to a phase 1 trial, right? But there's also some excitement because it's the earliest, most exciting drugs. A phase 2 trial is testing effectiveness. You've already found the dose that we're going to move forward on, the dose that's sort of tolerable in patients and that we think does the job. And so now we're going to say, in 30 patients, does it cause responses? Do people do better? And phase 3 trials then test survival. And these are randomized, which means that patients are either going to receive the standard treatment or they're going to receive the experimental treatment. The way I would look at this is that the drugs earliest on have the most risk. We don't really know if they do something, but potentially the most reward. Because if you find some cool drug that's right for you early on before anyone else is signing up for it, you'll have an opportunity to get into a drug that perhaps you might not ever otherwise see. A phase 2 trial, we have some excitement about it. We know we can give it to patients. It's hard to get on these sometimes. It's hard to find the phase 2 trial of your drug because often everyone else is trying to get on it too. It's like everyone's excited at this point. By phase 2, people are like, get me onto that drug. And by the time phase 3 comes around, people are like, shoot, I only have a 50% chance of getting the drug. But the rest of the people all get standard treatment. So for example, you've gotten your standard chemotherapy. You've grown. You now need the next chemotherapy. You either will get second-line chemo, pemetrexed or docetaxel, or you'll be randomized to some other drug. You may not know which one you're getting, but you know that you're getting the standard of care or something potentially even cooler. So early on, effectiveness, and then survival. The challenge here is that these get even more complicated more recently because we start getting phase 1-2 studies where a sort of phase 1 trial directly transitions into an effectiveness trial. And you're not quite clear, wait, is this phase 1? Are we just testing toxicity? Or are you actually trying to see if the drug works? Or phase 2-3 studies where everyone's being randomized to something and you're not quite sure what. They're all worth it. And we'll get into where do you fit for an individual place. I would say that these are the most confining in their rules. A phase 3 trial is a specific group of people. A phase 2 trial is a little more flexible, perhaps, and a phase 1 trial is the most flexible. And so it really depends upon you where you would end up in one of these places. Supportive care studies, studies of alternative therapies, all of those fit into here. You can do a phase 2 trial of whether acupuncture helps with migraine headaches or helps with cancer-related fatigue, right? And while you're getting your chemotherapy, you can sign up to get acupuncture as well, and they'll say, do people do better because they're getting acupuncture? And so all those kinds of trials also fit into this space. There was a phase, not a phase 3, but a randomized trial of patients getting chemotherapy for their metastatic lung cancer and patients getting chemotherapy plus palliative care referral to a symptom management expert, all right? So this was, everyone gets chemo, but they're either getting chemo for their cancer or they're getting chemo plus palliative care. Guess who felt better during their treatment?
Palliative care.
People seeing the symptom management expert. Guess who lived longer?
Palliative care.
The patients seeing the symptom management expert lived longer. That's fantastically important. Take care of your symptoms, and your wellness will allow you to live longer during treatment. Right? So all these kinds of trials primarily are for new drugs, but also apply to other therapies in development. This is really complicated. Who has questions about all this?
Neil does, but can you grab a mic? Oh, you have one. Yeah.
Just a question on phase 1 toxicity. So why maximum tolerable dosage versus minimum effective dosage?
A very nuanced question. Traditionally, anti-cancer therapies are toxic to the body and toxic to the cancer cell. It's in fact some differential toxicity that the cancer can't overcome the toxicity and therefore dies, but the body can overcome the toxicity and survives. And you dose them in such a way that the body can just barely make it through the maximum tolerated dose, because that way you're kicking the cancer as hard as possible, but you're letting the body recover. And that's the traditional dosing of anti-cancer therapies. The best example of that is erlotinib Tarceva, which was developed and eventually is now being dosed at 150 milligrams, which is the maximum tolerable dose for a cancer patient. By the way, when you give Tarceva to a healthy volunteer, guess what dose they tolerate? A lot less than 150 milligrams. All right, having rash and diarrhea, you can tolerate if you're living with cancer, but it's really annoying. And it definitely when you're like, when it's optional in the adjuvant setting. Someone has stage 3 cancer and is about to start Tarceva maybe afterwards, is that right? After the completion of stage 3 cancer, of chemoradiation for stage 3 cancer, we think you're cured. And so what we're saying is, should we sign up for optional Tarceva for a few years afterwards, just to try to help a little bit more, right?
What dose?
And the question is, what dose is best there? People have a hard time during the optional therapy tolerating a full 150 milligrams. And we've learned that from a clinical trial that's recently been reported where they tried to do this. They gave optional erlotinib after curative therapy for 2 years. And when people on full dose were like, please stop, I want to get off this. But when you brought the dose down to a tolerable dose, they were able to stay on it for the whole time. And part of the reason why we are comfortable bringing the dose down is because the maximum tolerable dose for erlotinib inhibits wild-type EGFR, not mutant EGFR. But mutant EGFR, which some of you have in your cancers, is affected by Tarceva at a lower dose. We know that I've seen patients respond to 25 milligrams, 50 milligrams, and what you're saying is, why don't we just use 50 milligrams? Right? Why don't we just develop the drug at the dose that works instead of at the dose that is maximally tolerable? It's a good question. And a lot of us are thinking about how we can revisit our drug development. Part of the problem is that when Tarceva was first developed, it was developed for all comers. And in all comers, it has some effect. And it was only later that we found out that EGFR mutations underlie its sensitivity in a large number of patients, and that in those people, lower dose is okay. And so in many ways, finding the dose depends upon your own cancer's biology. It's a long answer, but it's a tough question. Other questions? Someone else had one.
In phase 1s, because you're testing for toxicity or essentially fine-tuning your dosage in this may be more the traditional way of looking at clinical trials, aren't those trials usually of a rather short and defined period of time versus something that can continue on? So if someone's on it and it's working, the trial may, finish up and they're like, I'd like to continue on this sort of thing.
I mean, I think every trial, we're hoping for a home run, right? We're hoping that we're going to give some drug to someone and they're going to do fantastically well. and be on it for a long, long time. And so I think now that we have experience that some people find that they get a drug that works for them, they can be on it for a long time. Increasingly, trials build in that flexibility that if someone is having a fantastic success, they can be on it for a long time. And yeah, we have a patient at Dana-Farber who's on this trial that's still open, like 9 years later. And the company's still like giving them drug 9 years down the line because it's succeeding.
That's phase 1?
What's that?
That was a phase 1?
That was a phase 1. I mean, the drug's not in development anymore. I think the company may have folded, but they're still giving this guy drug because he's their success. So I mean, so it depends on the trial. I think, don't think that if you're a success on a trial, they're going to pull the rug out from underneath you and say, sorry, you can't have the drug anymore. Everyone's hoping that any given patient is going to be a success story. I think one of the most curious studies, clinical trial stories, is crizotinib, which was developed as phase 1 in 2006. Is when it first opened to try to get patients on this drug. It's now 7 years later, and it's a phase 1 trial that's still accruing patients now with ROS mutations, and that's the trial now for patients with ROS rearrangements. And it's because they're effectively doing this phase 1/2 thing. They're trying to keep the trial alive as long as possible, to answer as many questions as possible. And so if there are still questions to be asked and questions to be answered, these trials will hang around. A good example for all of this is immune therapies. All right, some of these people are really excited right now about these drugs called PD-1 inhibitors or PD-L1 inhibitors, okay? And these drugs effectively wake up your immune system, which is for some reason sleeping and doesn't see the cancer, and lets the immune system see the cancer again, and then in some people can do a great job at putting the cancer back to sleep. Right now, so when the phase 1 data came out, the phase 1 data was published in the New England Journal this past summer, and everyone was like, wow, there are some amazing responses in a subset of people. Not everyone, but 1 out of 5 patients had a fantastic response to some of these drugs, and that's really cool. And if you were one of those people who signed up for this phase 1 trial back when it was a roll of the dice, and you're just saying, I'll try, take something off the shelf and give it a try, then that's a real success. When that emerged in June of 2012, suddenly everyone wanted to be on these drugs. And so the phase 2 trials filled up rapidly. And by October, you couldn't find a phase 2 trial anymore because all the slots were gone. And then the phase 3 trials are now opening in March, April. And the phase 3 trials are randomized. If you want to get on one of these drugs, you have to sign up and say, well, I'll take the 50-50 chance of getting on the phase 3, on the experimental arm, or getting the standard treatment. No one's getting sugar pills. They're not getting placebo. They're getting standard treatment versus the experimental treatment. And so there's a timing element to all this. Sometimes you need to just take the risk and do the phase 1 trial because it might be exciting. Sometimes you're in the right place at the right time and you can get signed up for a phase 2 trial. Or sometimes it's the phase 3 trial, the randomized trial, that's your best chance of getting on drug. You can't control these things. And so while that's the story for the first of these PD-1 inhibitors, the next ones are coming out, and there's phase 2 trials here and phase 3 trials there, and there's a lot that you can't control as you pick where you'd like to fall in this flow. Yes?
How can we find out what's available?
Great question. So one place, we could ask some of our colleagues who are really good at online research, by the way, because some people are able to do this. A great resource is clinicaltrials.gov. So clinicaltrials.gov is every trial that opens anywhere in the world now has to register on this website. It's a laundry list. It's enormous. Now you can type in EGFR, lung cancer, stage 3. Yeah, and something might come up that maybe is a good fit for you. Sometimes you need to go get a second opinion from someone who studies your kind of cancer. We have a trial for stage 3 EGFR lung cancer that we're trying to activate right now, and we've got 2 patients on it. It's really hard for people to fly in from outside of Boston to get their daily radiation, all right? So it doesn't work for everyone. But for some people, it works. And so I think you look online and you try to find perhaps a second opinion from someone at a research institution who might know of what opportunities there are.
Jeff, sorry, I just want to add on to answer the question on our new website. It's like the big BJA plug, right? Yeah. On our new website, there will be a space that will help you to navigate that, because I know a lot of patients that I talk to, they've been there, and they're like,
Okay. So other possible websites are My Cancer Genome. My Cancer Genome is a Vanderbilt-supported website where you can look up your own genetic alteration that's in your tumor there, and it provides some basic information and has some clinical trial links that have been refined a bit. It still can be way too much information sometimes. And you can always ask Bonnie.
Yeah, well, here's the issue, and that starts getting confusing, because this all sounds fabulous, stage through the 3, phase 3, your EGFR, blah, blah, blah. But when you get down into the details, that's when it gets complicated. Like, you don't qualify for the trial if you have metastases to the brain. You don't qualify for the trial if you have blah, 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 blah. So, Jeff, what would you recommend? When people are really, they're at their wits' end, they've gotten on all of these sites and they still don't get it, what would you recommend that they do to get the right answer?
To get on the trial.
Yeah.
So,
or to even broaden that question, to determine which trial is best for them. I mean, it's one of those things where maybe there's 6 trials out there and they fit the inclusion criteria on all of them. How do they determine?
Right. Okay, so I would say, one, you do your research. You look around, or you get an opinion. If someone comes to me and says, here's my story, what trial do you have for me? I may or may not have one open at any given day. Right, so it's not like at most centers you'll show up and they'll say, here's the 6 options I have for you. Like, it's hard to find 6 trials that any given person fits into. What they'll say is, well, I think I can find something that you fit, but there might be an even cooler one, but you'll have to drive 10 hours each way to get to that one. So in many ways, it's just go to see which is going to be online research or going to be a second opinion. And that second opinion probably should be at an academic center that's fairly close to you, like somewhere you would go for treatment. I mean, please feel free to come see me. I would love to see each of you in clinic anytime. And I have treated someone on a clinical trial from far away in Chicago when it made sense and was a unique opportunity for them. Okay, and so we'll do that for the right people. But if it's for you, you'd rather just only drive so far, or you don't want to waste time on the plane or whatever, then maybe you have to go somewhere nearby. All right, so research and second opinion, but it's not like you should find the trial that you want. Unfortunately, you have to go see a doctor and say, here's the idea I have, what do you have? Let's work out a plan, because it's not all in your control. The rules about criteria and how you fit, and do you fit or do you not, and you can say, this is the trial I want, and they can say, well, I'm sorry, you can't go on that trial. You say, no, that's the trial I want, really. I did my research. And it's like, look, I'm sorry. The rules are the rules. In clinical trials, you have to fit into a box. And you have to be one of the people that they're looking for. And we don't make the rules. Those are all sort of set up in advance.
And this is one of the reasons, this is one of the reasons that so few people participate in clinical trials.
Yeah.
This is the biggest reason why so few people participate in clinical trials. But we can't let that stop us. We have to be our own advocates. We can help. Second opinions will help a great deal. We can't let that stop us. We have to do this because it's where the greatest
or make an impact, how we learn.
Impact is. Yeah.
Like right now, I'm on Tarceva. Should I be looking at clinical trials?
So I would say do it. So this can be done in advance. I mean, don't get me wrong. When you're doing great on Tarceva, the last thing you want to be thinking about is, oh no, Tarceva's going to fail sometime. What do I do when Tarceva fails? I'll admit, I want you to maximize your wellness right now and capitalize on the good times. But If you want to, listen in, go to some groups like this, think about what are the drugs out there. If it's interesting to you, clearly it's interesting to some folks to spend their time thinking about science. Yeah, if it engages you, don't be shy to go look about what's happening in EGFR mutant lung cancer, and so you can think about what kind of clinical trials you'd be looking for when the time comes.
And you spend a lot of time thinking about where you're going to be when you retire, and what you're going to do when you stop working, and if you think about every day all the things you think about before you had cancer, into the future, it's okay to do that.
And it's one of those things, Mary, and I think you were here, and Jim, I think it was your daughter who was who was talking about clinical trials, and she was talking about having that plan B in your pocket, right? Or plan C or D, depending upon which line of therapy you're on. But plan now for the future that you hope doesn't ever come, right? But if and when it does, you're prepared for it.
Stay engaged.
Definitely, you have to ask about trials before starting a new drug, right? Don't start a new therapy and then roll in for your second opinion and say, I just started this new chemo, but I'm wondering if you should think I should do a clinical trial instead.
Too late.
I'll say, well, you're ineligible anymore.
Right.
And so it's definitely, one of the reasons people don't do clinical trials is it is a lot of work. It's a lot of work for your doctor. It's uncomfortable for your oncologist to say, I don't know what you should do next, but I got a drug on the shelf. Do you want that one instead? And you say, no, I want you to answer me what clinical trials are there. I want to spend a couple weeks thinking about what are the clinical trial options before I pick the standard treatment. And so if you're in that transition period, take a deep breath and think about it a little bit. When I see patients with EGFR mutant lung cancer on Tarceva, I don't have them all drive in from where they're getting their treatment to see me all the time. I say, what I want you to do is come see me when the Tarceva is starting to fail. When you're getting a sign that things might be growing, that's a very delicate period where we're still learning about when is it right to stop Tarceva? Should you ever stop Tarceva? How long can you stay on Tarceva as it's starting to fail? I've had a patient show growth and then stay on Tarceva for 2 more years with slow, controlled growth, feeling great, before they finally went into clinical trial. They first had symptoms when they stopped Tarceva to go on the clinical trial, and their cancer grew more quickly. Look, that's a unique case. But my point is, it's that period of when to transition off a targeted therapy onto the next therapy is the kind of time when it's worth getting an opinion to say, how should this work? But I wouldn't just stop the drug because it's possible things could grow more quickly. Now, if you're feeling terrible, sometimes you just got to pull the trigger and start a chemo. But if you're feeling okay, there's more flexibility. And that's a time to look around for trials.
Do you know a site or a study?
Microphone.
What?
Microphone.
She's like, what?
Just like what? It's like relaxing.
I'm on a couch. Yeah, it's relaxing. Do you know a trial that would fit my mom, given the...
We can talk about that later.
Okay.
Right. Complicated question. Because your mom's a unique case. And the more unique you are, the harder time you find getting on clinical trials sometimes.
Right.
Yeah.
Oh, yeah.
Something I just, to your point, when I was on kind of the maintenance of Avastin, and I went to get a second opinion just to kind of figure out, okay, what's out there, because there are so many different approaches to, especially lung cancer, especially at that time with my BAC, there was a little known. I got a second opinion. That's when I got the molecular and genetic testing, and so that we kind of had that information, and he was able to get, make a more informed judgment. And because I was on a clinical trial before, I also wanted to participate in a clinical trial at the point when I started to progress. But the organization, where I'm going, the institution that I'm at right now is UC Davis. And what they're doing is that they're starting kind of a program, and I think this is something that is kind of starting a trend, that in the first clinical trial I was at, it was at another institution, and they just had their little group of clinical trials that they did. And basically they just wanted to offer me a clinical trial that they offered, versus an approach that UC Davis is doing. It's a little bit more comprehensive, because within your area they're not only looking at UC Davis, but they may be looking at UCSF or even Stanford or somewhere where a clinical trial may be more optimum for that particular patient, saying, and your doctor, your oncologist saying, you know what, you may want to go to this institution because I think, in my judgment, this may be a better fit for you.
And that's why being seen for a second opinion can help, right? I know the kinds of trials that I have open at my center, but I also know that MGH across town has some different kinds of trials open, that Yale, a couple hours away, has different kinds of trials open. And so I try to keep a sense of what kind of trials are available for patients. A, for the patients who I'm caring for, because I want to be able to send them to places, but B, for the patients I'm getting second opinions about, that I say you might want to try this place or not. And I think that's because patients are becoming more and more individualized, and it's not possible for every center to have every trial open. And so instead, you have to have some trials open and have to be able to refer to other centers for other kinds of trials.
And they actually have a person who is helping with that coordination. So they'll say, well, you need to go talk to Sally. She's kind of the coordination person, and she can help that person facilitate that. Because really, I mean, I went on I was in biotech, and I went on, the clinicaltrials.gov and talk about, information overload and everything. And you're like, oh my God, there's no way I could sort through this. And I have a little bit of, enough knowledge to be dangerous in that respect. But having someone to help you in that regard, in addition to the oncologist, kind of giving them guidance and saying, okay, these boxes are the criterion, the killers and the criterion. Either you meet them or you don't, and then that will tell.
But in the end, it is a lot of work. And you can show up at the center and say, I'm here, I'm for the trial that we talked about, and they say, oh, I'm sorry, you have brain mets? I didn't realize. No, you're not eligible. It's just like, what? We've been emailing. Why didn't you tell me? And it's like, it just has to, you have to go through the process. And sometimes it works and sometimes it doesn't. And sometimes you stumble upon a little alteration in your kidney function, and they say, you don't fit. I had a patient, I started on a clinical trial for erlotinib resistance, and she consented and she got started and got her biopsy to get going, got the biopsy, got started on the new drug, and the biopsy showed that the cancer had changed to small cell. Small cell is an aggressive type of lung cancer, and we see this transformation rarely, but we see it in 1 out of 10 or 1 out of 20 patients. And I said, that clinical trial we just started? It's not the right one for you, I'm sorry. We should do chemo instead. And we had to change the course because of the results. And that flexibility, that uncertainty, that's living with lung cancer, right? And you just need to adopt that a little bit and say, I can't control it.
And that's why we tell everybody that we work with, you're part of the solution. Gone are the days where you just go to one doctor and listen to absolutely everything they say, like a good little soldier, and just hope for the best. You're part of the solution. The solution is in your body. So the better you know your body and what's happening to your cancer, that you can communicate to the people that are taking care of you, the better treatment you're going to get.
Jim, I think you had a...
I don't want to interrupt you.
Well, we're rolling. Keep them coming.
To Danielle's point, the field is changing so fast. Nita and Laurie and I decide we'll always be in information gathering mode, always be here every month, and we see articles and so forth, but we don't have a targeted clinical trial that we're ready to jump on because it's changing. I mean, there'll be new ones coming out all the time, so I think if people are fortunate like us who have the resistance is, Tarceva is still very effective. Don't spend a lot of time, pinpointing, I'm going to get into that trial at MD Anderson just as soon as the Tarceva starts to lose its effectiveness. I think it'd be a waste of time. And there's always a desire to do something. You got this monster in your body, do something.
Okay, so do something. So how do you prepare? Prepare your body, so to speak. All right, for just a recap, I said, do your research online or get a second opinion. Ask about trials before starting a new drug. Pester your doctor if they're not bringing it up. Get genotyping. Fit into a box. Right? You got to fit your cancer into a box if you're going to figure out what the next trial is. And you could be a magical case, and we don't understand if it's a pemetrexed or erlotinib, but man, figure out there's got to be some genotype there, right? And so let's figure out what it is, and that's how you characterize your tumor so it fits. Don't call yourself squamous cell carcinoma when it's adeno, right? Fit into a box. And then prepare yourself, which is maximize your wellness, right? The people who get on clinical trials are the people who are doing well, are the people who are staying strong. And my 3 rules of living with lung cancer, and I've told this to some of our audience earlier, are don't act sick, Even when you feel sick, go out and do stuff. Keep your body strong, keep your mind strong. You need to maintain your activity level and your wellness. You don't have to go play basketball. Just do things, and your body will stay strong enough that you're going to be ready for the bump on the road. Don't lose weight. We know that weight loss is a bad prognostic sign. I like all my patients just 10 pounds, a little bit too chubby, because that's in case you have a rainy day. You can lose those pounds on a rainy day, and there are rainy days in the lung cancer business, okay? And so have extra pounds on. All my patients, I encourage to eat an ice cream sundae every night. I prescribe that. Yes?
Well, while you're on that subject, our daughter's lost a ton of weight, which is a bad reaction to the last chemo that she had. And she's way down in her weight. And she's trying to eat, but she has no interest in eating. She's not hungry.
So before you leave, we should talk about appetite stimulants.
And
there are like 4 or 5 of them.
Absolutely.
And we should talk about which one you can use, but sometimes you have to be innovative. Appetite stimulants.
And just for the people at home that might not have heard her question, Linda was asking about weight loss, and I know for you it was a big problem, and for a lot of patients it is because of the lack of appetite and the nausea and the whatnot. So that was the question.
Doctor, that's what's happening to me right now is I'm losing weight from, I'm just not that hungry. And on the Tarceva, you get the diarrhea. And so if you eat certain, like cheese and things like that.
If you want to prepare yourself for clinical trial, get yourself back to the weight you used to be.
But how do you do that?
Okay, that's what your chore is. That's your hobby for the next 6 months.
It's volume. It's volume.
Right? And it's figuring out the diet and figuring out the calories and maybe adjusting your dose. If you're losing weight on that dose, then drop the dose maybe.
But like Jeff said too, it's the appetite stimulants. I remember I was on steroids.
But no, Bonnie, for me it's like when I eat, normal food, then I get diarrhea.
Okay, how many diarrheals do you take in a day?
The antidiarrheals?
Yeah.
I don't like to take them.
Well, okay, number 3. Don't be a tough guy. Don't be a tough guy.
But then I get a stomach ache.
Don't be a tough guy. How do you treat your stomach ache? Fine. One pill leads to another pill. You're going to have a lot of pills you're on. Look, you can lose weight, but you won't get on a clinical trial. All right? If you want to maximize your opportunities, don't act sick, don't lose weight, and don't be a tough guy. All of us everyone before cancer was relatively well, and then they became a cancer patient, right? And it changed your sense of wellness, and disease became yours. I need to rant like this for a second.
That's okay.
And therefore, you start taking pills. It changes everything. Yes, you're going to be on a lot more pills than you used to be on. And learn how to page your doctor, and learn how to complain, and learn how to speak up. The worst is the person who's doing really well on a pill. They're doing fantastically well. Doctor says, you're doing so well. I'll see you in 3 months. Keep up the Tarceva, scan in 3 months, fine. 2 months goes by, and they start feeling sick. And they start getting pain, or they're starting to get dizziness, or they have some crazy symptom. They're like, I'm not supposed to see my doctor for another month, so I'll just hold off and see him in a month. 2 weeks go by, and they're getting worse, and they can't walk. Finally, 3 months comes around, and they're rolled in a wheelchair, and the doctor's like, why didn't you call me? And you said, see me in 3 months. And I said, well, not if you're falling apart, right? The people who are stoic and tough about their symptoms and saying, no, I won't call the doctor, they don't go on clinical trials because they're too sick, because they don't stay on top of things. And so you cannot be passive about your symptoms. People on treatment should feel well. We have all sorts of tools to allow you to feel well. Don't allow yourself to suffer on treatment.
And eat a lot of what you can tolerate. I ate mashed potatoes and butter like there was no tomorrow.
Eat all the sugar you
5
want.
times a day.
There's no problem with sugar in lung cancer.
There isn't?
All I know is my patients who do well don't lose weight. When your weight's back to where it was before, eat whatever you want.
It'll never be back.
But that's the truth. When your weight is robust and you have extra pounds on that you can afford to lose when you get sick, because you will get sick, then you can eat whatever refined diet you want, whatever diet's okay. But my patients eat sugar and they feel great, and they thank me for it.
Every day is okay?
Please.
Absolutely.
Every day.
Absolutely.
Twice a day.
3 times a day.
And call me
With
back
a bowl
when you
of
gain
mashed
10
potatoes,
pounds.
it's fine.
No, the sugar, yes, sugar feeds cancer cells and your brain and every other cell in your body. Your body likes sugar, right? If you have diabetes, please avoid sugar because it'll make your sugars go crazy out of whack, and that could be unhealthy. But there's no clinical trial data to say that sugar impairs with lung cancer patients. Colon cancer, if you have colon cancer, it's a cancer of your GI tract, and diet is more important. But in lung cancer, the basic rule is people who don't do stuff don't do well, and people who lose weight don't do well. My patients aren't allowed to lose weight.
I have a question.
Yes.
And, with being newly diagnosed, I've heard of so many people that have come to me and say, go vegan, get healthy, eat healthy. And I've seen documentaries like Forks Over Knives on so we hear of the benefits of sometimes eliminating animal proteins.
Yep.
And so my husband and I have been following this diet, and both of us have lost, probably about 10 to 20 pounds each. And I feel better, I'm healthier, but I'm taking the maximum levels of Tarceva. But knowing that sugar is okay, doesn't that also counter?
Wait, all those documentaries are for healthy people who are trying to avoid getting cancer. If you're a healthy person, don't want to get cancer, I encourage you to avoid whatever you want, eat as healthy as possible. There are all sorts of things that non-cancer patients should do to stay healthy. But when you're living with cancer, the risks are just too high. And weight loss is terrible, and we know it.
Okay. And what about changing some of your eating habits? Though, does that have any effect on maybe can it help cancer not grow as much, or does it have some kind of your diet have some power over the cancer?
I think there are plenty of people who support that concept. There is not scientific data to support it in the way that clinical trials would show, and there's never been a clinical trial to show that any of those diets change cancer. There's anecdotes. We can make up all sorts of anecdotes, as I said, right? But you can't get 30 patients together who went on a vegan diet and their cancer shrunk. No.
Okay.
But I can tell you 30 patients who lost weight and never made it to the next treatment because they lost too much weight.
That makes sense.
Why is weight loss bad? Do you know why?
Because it's a sign the cancer's winning. It's the oldest sign in the book that the cancer's winning.
And you have to be ready for the assault on your body.
Right, because if you get pneumonia and you get admitted and you lose 10 pounds, people who are chubby can afford that. And people who are skinny can't. No, please.
I had lost about 10 pounds, not in a short amount of time, but I had trouble eating.
Yeah.
I would wake up in the middle of the night and throw up.
Yeah.
I was dreaming, And my doctor put me on a steroid, and I take half of it each day. And you hear this old thing about having 6 small meals a day. How about 12? I can't stop eating.
No, wait,
and I eat anything I want.
Plenty of people lose weight. I'm not saying, look, sometimes you lose weight. I know, and sometimes that's, that's
I've gained it back.
But I'm just saying is you can also try to empower yourself to treat these symptoms, because it's a symptom that we don't like. And don't be okay with it if you can afford to try to fight it.
There's no room for vanity in cancer.
Yeah, and I just think about, what am I hungry for? And something will come to mind, and that's what I eat.
Good.
I just have the weirdest diet, and I live in an independent living, and they have 2 meals a day, but I just go to dinner, and it's, I've gained all that weight back again, and I feel really good about eating.
Good.
And I eat a lot of brownies, so I'm glad to hear
I think it's hard enough living with cancer, right? Not to mention not taking chocolate, right? And also no sugar and no grandkids either. It's like, what are you going to do? Stop making rules. I'm living with cancer here, so liberalize me a little bit. And that's what I say.
Well, and I think that
spouses too?
Yes.
No.
Yeah.
Congrats on the weight loss. Congrats on the weight loss. Okay.
I want to say something to Mary's point. And sometimes patients will say all the time that they're just not hungry, right? Well, in your cancer space, and when you've been living with cancer for so long, that becomes part of the norm, right? But recognizing that just not being hungry for days on end is absolutely not normal. That is not that's not the way your body normally reacts towards hunger. right? You're hungry. That's what people do. So when you get to that days on end, but for patients, I could see where when they've been living with it for so long, they're like, well, it's not a big deal. I've been doing this for a really long time.
And they stop complaining. They stop saying to their doctor, why am I never hungry? They say, oh, I'm supposed to not be hungry because I have cancer. It's like, no. You can be hungry. You can enjoy brownies.
Yeah.
You know, it can be yours. Just call your doctor and say, I'm tired of not being hungry, and I want to talk about what you can do to help my hunger.
Yeah.
Think of all those things you didn't do before when you had the 2-pound box of C's at Christmas and thought, oh, I better only have one. Have the whole box. Do it, you know.
I'll have to say the reason I stopped eating sugar because I read that cancer lives on sugar. And so it's like I'm trying not to eat ice cream, cookies, you know, brownies.
I think once you feel like your weight is at a healthy weight, where your clothes fit like they used to, and where you're back to the healthy weight for your body, you can eat whatever healthy diet you want. But when you're losing weight, you need to liberalize your diet and get yourself back to the place that's good for you.
And I think, to again, Mary, to your point about the sugar, is I talk to patients all the time who say that very thing. Oh, sugar. I can't, you know, cancer like sugar. And going back to what Jeff said a little bit ago, and if you, as a patient though, it's difficult. They're getting on the internet. There's this deluge of information.
I mean, the other thing is supplements, right? You go see anyone like in alternative medicine, they say, you definitely need to take all of these supplements, and you can buy them for me in my closet right here for X amount of money. So like, if you're gonna go get advice about alternative medicines, I think that's fine. Just make sure the person who's advising you is not also selling you the same pills, right? I'm a big believer in which vitamins to take to make chemos more effective, but in general, we have to be careful about them because they might interfere. Right. And so just be cautious. I'd rather spend my money on ice cream than coenzyme Q.
And you know, I remember when I was doing this, you know, a couple of times, and I was on steroids, and I literally went from eating nothing to wanting to eat the living room furniture. And I did, you know, and it felt good, and I got my weight back and then some, and I got to the chubby place, and I didn't care because you know what? Do you want cancer, or do you want to be chubby? I mean, look, I'm voting for chubby, right? Who cares? You need to always be ready for that next assault, because chemotherapy is toxic. It just is. Exactly.
And cancer's toxic, right? And that living with lung cancer is living with unpredictability, blood clots, new metastases, bumps in the road. Yeah, they can happen tomorrow or next week or a year from now, and we don't know when. But anticipating that there is uncertainty when you're living with lung cancer, and there can be a big roadblock not that far away. We can't control it. We just have to say, okay, every day I'm going to make myself as well as possible. Well in this way, not in the way your spouse is well, so that if there's a bump in the road, I'm ready.
Terry, throughout these last 3 years, we've done a lot of research, and when it comes to the diet and whatever, and I agree with regards to the weight is important, but also what we found is there is one area that I think diet is important, is to find out what you're allergic to, because there's a lot of food allergies that you're not aware of, which is if you do have an allergy, like I have egg allergies, which I never knew. And it's not one of those ones that I got drastically sick, but my body was it wasn't a food allergy. So what happens if your immune system, if you're eating stuff, which is basically one of the things that you can control when you, as a human being, rather than a lot of things that you don't have control of, is if your immune system is fighting this allergy of what you're putting inside of your body, it's taking some of that strength of it that it has to have to fight the cancer. So if you're not allergic to sugar, that's one thing. Go ahead and eat the sugar. But if you're allergic to a food and you keep on consuming it, you might not know. So I recommend getting food allergy testing.
I do not. You're welcome to. I don't recommend my patients to see allergies for food allergy testing. Like, there's a lot of stresses when you're living with lung cancer, and I don't want to add extra ones, but I don't send all my patients to allergists. If you eat eggs and it doesn't make you feel good, don't eat eggs. But if you enjoy eating eggs, I don't want to find out that some allergist is going to tell me I shouldn't be taking it. And so I'm not convinced that that applies to all cancer patients. But if it improves your sense of wellness, then I think it's fine.
But what happens if you're on the treatment and you're getting these stomach pains and you attribute it to the chemo and it isn't the chemo.
Okay, if you're having stomach pains, then you can pursue the workup for stomach pains, and sometimes that is looking for foods that aren't causing stomach pains. But I'm just saying I don't routinely do it for all of my cancer patients. I agree with you, though. Any given symptom that comes up, I would aggressively manage it to make sure you minimize it and find out how to treat it. And sometimes that's finding a diet that will minimize those symptoms. You're right.
So I have a couple of questions from online that I want to make sure to get to. They kind of backpedal. So since we're talking about the nutrition portion of this, one of the questions is, I'm going to give you two. One is, what about juicing? And the other is, what's the best appetite enhancer?
Okay. My favorite juice is ice cream juice. I mean, a big glass of kale juice is fine if you're not losing weight. If you're not losing weight, eat whatever you want, juice whatever you want. But if you're drinking a big glass of celery kale juice instead of drinking something that has actual calories in it, then I think juicing could in fact be bad for you. And so I think it depends on the person. But I'm not averse to any specific diet as long as you're not losing weight, right? And if your weight's in a plump, healthy place, then you can eat whatever cool diet you'd like. Personally, I just find the juicers really annoying to work with, but it's just frustrating. It's just, you got that pulp, you put it in the mulch, and then what was the second question?
To increase the appetite, what drugs are?
So there are a lot of drugs for appetite, and each of them work in about 20% of people. And you don't know which 20% you're going to be. And so we start with a drug called Megase, which is a hormonal drug, which in some people really helps, and in other people doesn't do anything. And then if it doesn't do anything, we switch to a drug called Marinol, maybe, or Dronabinol, which is a marijuana-like drug. And that works in about 10% of people. And I've had someone take that and just feel fantastic, and suddenly they're beating their cancer, and they're like, I can do it again. But that's not most people. That's 1 in 10 people. And then if that doesn't work, I try an antipsychotic drug. These are drugs for craziness. And their side effects are you sleep really well and you get hungry. And I'm like, oh man, that's a great drug for a lot of my patients. And so olanzapine or quetiapine, also known as Zyprexa or Seroquel. And I've had a patient who just was doing terribly on chemoradiation and was just like, oh my gosh. And she was falling apart in front of me. And I started this drug, and she gained 15 pounds in 2 weeks. And I was like, oh, sometimes it just requires trying different drugs. A lot of my patients, I give a drug called Remeron or mirtazapine, which also I call vitamin R. It helps with mood, it helps with appetite, and it helps with sleep. I mean, what a great drug, right? So I give that to a lot of my patients. So I think there are different ones. It's hard to know which is going to work for you. But what it means is give it a try. And if it's not working, try something else. Steroids work. In the short term, they're very good. In the long term, they can make you weaker, especially and they can make you weaker here in the legs. And so we have to figure out the right dosing for people. And so we use it in some settings, and it's a conversation to have with your doctor.
Okay. Then there was, I'll get to the KRAS question in a second. As a stage 4 non-small cell patient, Avastin has failed after 4+ years. Oncologist suggesting surgery or targeted radiation. Should this patient be looking into clinical trials instead?
So local therapies have a role in stage 4 cancer on an individual basis. But they are rarely, if ever, curative. Local therapies can be used to treat a painful bone metastasis, give radiation. Local therapies can be used to treat a growing brain metastasis, take it out with surgery. But systemic therapies, medicines, often on clinical trials, have a better chance of controlling the entirety of the disease we can see and the disease we can't see in all the different areas. Someone who was about to start on 7 weeks of radiation, who was that? Your mom. Right? So 7 weeks of radiation is a really intense radiation course that we use for curative therapy for people who don't have stage 4 disease. So if that's stage 4, that's a really aggressive course that could potentially make you sicker. And so I think local therapies need to be considered, and we'll wedge something out and try to get you back on track. But systemic therapies also should be considered. So it's very hard on an individual basis to walk through it. The easy answer is everyone should consider a clinical trial, because at least then you're not an N of 1. You're being studied as a group to try to actually learn if a drug's working.
This one's going to get tricky, and then we're going to get a little bit back into tumor testing, if, when, where, why, and how. There's a patient who was diagnosed at stage 4 disease, went through chemoradiation, actually went to surgery for a curative effect, and now looking into a potential vaccine.
So, and again, this is an instance where we have tried to convert a stage 4 cancer into curative and use a local therapy. We do this sometimes.
Which, sorry, I don't mean to interrupt, but would you effectively call that like a trial of one? Like
No. There are anecdotal stories of a person who has a lung tumor and a brain tumor. Both are taken out, and the cancer never comes back. That's stage 4 cancer that gets cured. That's fascinating, right? There's not big clinical trials showing it, but we definitely know that in some people you can do that. And so, when we have a chance, yeah, we try to turn a stage 4 cancer into a cure. Mesothelioma, I mean, there's a cancer that we have learned if we throw the book at it, some people do terribly, and other people do amazingly well. And you got everything done, the lung, the radiation, the chemo, and here we are years later, right? And you're a success story, but we also have clinical trials showing that if you try to do that to 40 people, they're going to do awfully. Because sometimes it's hard to apply a rule to a bunch of people that you would apply to a single person who's doing really well. And so it's just sometimes hard to apply the rules to everyone the same way.
I went to the right place, though.
Right, exactly, right? That's my point. That's totally true. And sometimes it depends on who's doing it. And so I'll admit that it's, from vaccine therapies, there are some adjuvant vaccine therapies. I would say that this person would probably not be a candidate because they've had such individualized therapy, right? If stage 4 cancer is gone, like that's an amazingly rare case. And so it's hard to find 30 people like that to put in a clinical trial. And so I'd say probably that person can't get on a trial because they, from what it sounds like, they wouldn't be eligible because they're too unique.
I believe this was talking about T790, and if you're still online, re-ask the question if I get this wrong. Can you explain what familial means in terms of how genes are passed down as opposed to acquired?
Great point. So genotyping means taking DNA and looking for mutations, sequencing the genes. And genotyping can hypothetically either be done on the person or on the cancer. And I'm talking about cancer genotyping the tumor, right? The tumor's genes are the genes that explain the tumor's biology. Familial cancer, familial traits, inherited genes are the person's genes. We rarely test that. We don't have really many genes in the lung cancer world. You might know about BRCA mutations that lead to breast cancer risk. Those are inherited familial genes. All the genes we talk about in lung cancer are the cancer genes, EGFR and ALK and KRAS and ROS. These are characteristics of a cancer that help us treat it. And those would not be found in the person, except in this one clinical trial we're doing of inherited EGFR T790M, where 1 in 1,000 patients with lung cancer will have this T790M in their blood. And that means it could be a familial cancer gene for lung cancer, and we're trying to study that. And so right now, the only people we're studying on the inherit EGFR study investigating hereditary risk from T790M, which is sponsored by the Bonnie J. Addario Foundation, is people who have T790M in their cancer, and we think it's actually in their person's genes as well, and that's how it got there. I think that answers the question, perhaps.
I think so.
We'll have to see. Yeah.
As Bonnie does also, a family history of lung cancer. My grandfather, paternal grandfather, my mother, her brother, and then myself. And mine was only found because I put myself in an early detection study, the international one. And I worry about other family members. My tumor was never tested.
When you study a bunch of families who have a bunch of lung cancer, the gene that most commonly shakes out is a gene that has to do with nicotine metabolism, which perhaps means that in some families, this is all we've got to go on, okay? We've tried. They smoke more, perhaps, because their body eats up the nicotine. It's not a very satisfying answer, is the bottom line, okay? And so we don't quite know why some families get lung cancer. If you come from a family that gets a fair bit of lung cancer, the best thing to do is don't smoke. But we don't otherwise recommend genetic testing of a person's blood or recommend routine CAT scans or x-rays on someone based on a family history. We just haven't learned enough. This one unique situation we're studying with familial T790M is a little bit different, and we would suspect that if the cancer had T790M in it, and if that is found, we would then test the person to see if it was in their genes as well. But we are not routinely testing someone with a family history of lung cancer to see if they have EGFR T790M because it's just not that common. And so we don't want to put a lot of people through the stress of testing and find negative results. Does that answer your question, kind of?
Do you recommend that at a certain stage in life that people that have this familial, like go get a scan like you would do with a breast?
We do not.
Okay.
And it's not been studied. It's not been studied very well. But I think it's certainly worth being vigilant if you have a family history. But the fact is, there's a lot of lung cancer out there, and it's hard to decipher what of the risk is inherited risk and what of the risk is environmental risk. Right? A fair bit of the risk is environmental risk from inhaled this and that, from inhaled smoking, from inhaled asbestos. These environmental risks are such a major component of the risk that if you just eliminate all environmental risk, we might be able to study inherited risk, but it's hard to separate those things. So far, we've not had something to focus on before now.
Thank
you. So this goes back to tumor testing and molecular profiling in general. One was a woman, I say woman, oh yeah, woman, she. When asking her oncologist about molecular testing, he said if she ever needed surgery, they might do it, but testing would not benefit from a clinical standpoint.
So I think the people who should be routinely tested for EGFR, ALK, and KRAS mutations, this is my practice. Mutation testing, which is all patients with advanced, which means stage 4 or cancer that's come back after surgery, advanced adenocarcinoma. And all those patients, I will test EGFR, ALK, and KRAS. And that is a fairly widespread standard practice at academic cancer centers. Patients, this person might have an early stage cancer, right? If you had stage 2 cancer that was taken out, some would argue it's not necessary to do genetic testing unless the cancer comes back, at which point if it came back, we would test to then study what to do next. If you didn't have adenocarcinoma, if it was squamous cell carcinoma, we conventionally wouldn't test. Though in someone who didn't smoke or was young, I would generally test for genetic changes anyways. In patients who are negative for all of these, I might test even more, and that's where we start getting into ROS testing and other mutations because we're trying to find something. I think if they want a clinical trial to be an option for them and want to maximize their chances, then getting genetic testing would be the way to go. And again, a clinical trial is not routine practice, right? You may get the result and it may not impact your treatment, but it may impact your treatment down the line because of clinical trial options.
So this is a stage 4 adeno patient.
I would routinely test these people for EGFR, ALK, and KRAS. It may not impact right now, but it would definitely impact me down the line.
And then,
Jeff,
go ahead.
Can you talk just for a second about how someone one day is EGFR and then their cancer progresses or they're retested, rebiopsied, and they're ALK?
I have not seen that in my practice. I know Dr. Camage and others in Colorado have described that a little more commonly. I think it's uncommon, and so I don't always test people for both EGFR and ALK. That's still a little bit up in the air. In my personal practice, I think EGFR is its own disease, and that defines the cancer for the entirety of its existence, and ALK similarly is its own disease, and KRAS similarly. I think KRAS testing is important because if you have a KRAS mutation, it means that we shouldn't be looking for other rare mutations like ROS. That means that's your biology. Now, we don't have a treatment for that right now, but we have clinical trials in development and we want to have treatments. What can happen is after resistance, other genetic changes can occur. So after erlotinib resistance or crizotinib resistance, and in those individuals, we'll often do a biopsy to try to understand what's now explaining the cancer. And in rare instances, you will see a different mutation there.
Okay. So we've also seen, and there's quite a few EGFR positive patients in the room and online, where they were on Tarceva, progressed, went on to something else, but then they were able to take Tarceva again down the road.
And we think that's because the cancer is still addicted to that signal. So even after developing resistance, the cancer is still addicted to EGFR. And even though you're reaching for a new treatment for the new characteristics of the cancer, the T790M, or trying chemotherapy, I will always continue the EGFR inhibitor to control those cells that are still EGFR addicted. And there we have some retrospective studies to show that in patients who have acquired resistance, we call that AR, to Tarceva, if you give them chemo versus chemo plus erlotinib, that the people who get chemo plus erlotinib do better. And that's a retrospective experience. Prospective trials going forward to answer this question. Clinical trials are being done, right? And so what we need to do is get 200 people to be randomized to either chemo or chemo plus erlotinib, and we'll answer that. We're just trying to get that trial together.
So somebody online, and you just touched on it, so it's probably a good time to talk about it, wants to know what's going on in KRAS right now.
There was the first positive trial ever in KRAS this past year in KRAS mutant cancers, which was very exciting, presented by my colleague, Dr. Pasiane, at ASCO this past year, where patients with KRAS mutant lung cancers were either received standard chemotherapy with docetaxel or added to the docetaxel a MEK inhibitor, and they find that adding this targeted therapy to chemotherapy made chemo stronger. And the results were impressive. It was also a very toxic combination. So it's a positive trial, but it's a little bit concerning because of the toxicity. And so now what we're trying to do is figure out how to give that combination better. And so trials are now opening to restudy that same regimen in a different way with different dosing. And so there are now KRAS mutant trials that are opening to answer that question. These are going to be phase 2 randomized trials. So I think there will be newer options coming in the near future. I think we always have trials for KRAS, but not as many successes as we want.
Okay. Anybody else have any questions?
Hi, can
Lynn.
you just touch upon the exon number 20, the EGFR, just because I got tested positive for that, and I am on Tarceva right now.
Okay. So one of the uncommon EGFR mutations, this is 10%, are called exon 20 insertions. And when we say exons, we mean that the important part of the gene is broken up into areas that contribute to the protein in different ways. 18, 19, 20, 21 are the key areas in EGFR, and we know that the mutations that are more sensitive to Tarceva are in 18, 19, and 21, but the ones in area 20 are not as sensitive. And when I described previously our experience trying to talk about a rare group, looking at thousands, I found 30. This was describing our experience with EGFR exon 20 insertions. And I think most studies are showing that erlotinib does not do a whole lot. Now, I'm not saying it's not worth trying, but it's disappointing. There is one subtype of the exon 20 insertions where we think erlotinib does work. And this just makes it even more complicated, right? It's like, oh my gosh, just, you know, and this is like 1 out of 20 of those. And so try to get 30. If it took me 2,000 patients to get 30 exon 20 insertions, how am I ever going to find 30 of this one subtype to study? It's very hard to do. But there is a scientific story being developed by a colleague of mine at Beth Israel Deaconess, also a Harvard hospital. His name's Dan Costa, to try to characterize that science. I think we're finally making headway, will be the quickest answer. And the first clinical trial ever focusing on that specific subgroup, exon 20 insertions, will be opening shortly at MGH and Dana-Farber using a drug called AUI-922, which is an HSP90 inhibitor. If you want a treatment, come on by. But it's the first trial ever to try to focus on that group specifically.
I was actually on a phase 1 clinical trial beginning of January with Tarceva and davitinib which is an FGER.
Oh, davitinib, yes.
Yes.
Right.
Unfortunately, the Tarceva responded, but the davitinib did not.
Interesting.
So I immediately stopped after 5 days.
Okay.
So.
And in one of the clinical trial, the downside is toxicity, right? You're signing up for something. If it's not working for you, do you stay on it? Do you switch? That's a struggle. But I think if you need another treatment, there's an option out there, and certainly think of us. Okay. Yeah. How are we doing on time? Can we keep in questions? Is that okay?
Yeah.
Great.
I had surgery, stage 1 lung cancer in 2003. And then a few years later, they found all these spots, and they called them ground glass and all sorts on both lungs. So I'm missing the top lobe and the center lobe. At that time, no one was doing any testing on mutation at all. So when I saw Bruce Johnson at Dana-Farber, when I went there, and I went everywhere, many places. He said, we have to do this testing, that we're the only one at Dana-Farber doing this.
Right.
So he requested the block from the surgery from Stanford. The surgery was at Stanford. And he did find a mutation. And I don't live in the past, sort of, so I always forget the name or what it was, because I'm always in the present and moving on.
I think that's fine. The point is, if you need to plan a treatment down the line, what you know is that the data's been collected and it's sitting somewhere.
One mutation, though.
Right, and
because
so
they didn't know how to do more than that, and only Dana-Farber could do it. Now, since I have all these spots, would it be a good idea to test for other mutations?
If you have spots that aren't growing, enjoy it, right? What we've learned is that lung cancer is very heterogeneous, and some of them, they hang out.
Yeah,
and people can carry on living with these widespread process.
Ground glass on one side, many of them.
And we might call them now lipidic or precancers or adenocarcinoma in situ, meaning it's not yet invasive. It's, in breast cancer, we would call it DCIS, which is this precancer. Now, in breast cancer, they chop it out or radiate it because it's your breast, right? In lung cancer, we can't really do that. It's your lungs. And so instead, what we do is we have to watch. And often people can do fine for quite a while.
So that it wouldn't be advantageous to know now if I have other mutations?
I don't think you have to worry about it now. If you have to plan treatment down the line, that's the right time.
Oh, I see. So just watch it when I do my CT scans. Yeah. Okay, thank you.
So I'm going to do a quick wrap up for purposes of time, and I think Dr. Oxnard will maybe be available for a few minutes afterwards to answer any other questions you guys might have. But I wanted to go over a couple of things with everybody. One, being that I just got news that I thank you guys in the room here all the time for sharing what we are able to experience here with the world, and we truly are experiencing it with the world. We have 5 countries representing tonight. Japan, U.S., Australia, the UK, and Canada. So that just goes to show you that so hello to everyone around the world, and thank you very much for signing in. Just goes to show you what it is you guys are sharing with everybody and how important it is. So I want to say thank you for that. I also want to say that I think it was probably about, well, I was going to say 2 months, but that would be a lie because I know it's been longer, that I told you guys about the handbook, the Navigating Lung Cancer, the answers to your questions in language that you could understand. And this is kind of a tease because it's not really available, although it is. It's at the printer, I know. It's like this big drum roll thing. But the book is done, and I'm happy to say that it's at the printer. It is available electronically to any of you who might want it now because you're too impatient to wait, like I was, which is why I printed it on our little machine upstairs, which is not quite the same, but I just needed to see it. So let me know if you want an electronic version. Otherwise, it'll be about 2 weeks before you can get the hard copy version. As I promised, it is not bound. So as information becomes irrelevant, it will be pulled. And as new information comes in, it will be easily replaced by all of you who have access to it. So anybody who wants to take a look at it before you leave tonight, it is here. I also wanted to give a shout out to anybody who might be watching from Chicago. because Danny and Amelia are going to be there next week doing some cultivating for our run out there. And Danny jokingly said she needs a place to sleep, but she really doesn't. But if you're out there and yeah, if you happen to be out there, she'd love to see you. So ping me and let me know where you are, and maybe you can set up coffee, lunch, or cocktail, whatever suits you. Yes, and with that being said, my beautiful mother and sister will be in Ohio. So if there are any of you, and apparently it takes a day to get there, and they're only going to be there for 2 days, like a 4-day trip, and they're only there for a day and a half. But there's no direct flights in to see Dr. Carbone. So we do have an event there. But
Ohio.
Yes.
Love you, all you Ohioans.
Yes.
But we need a direct flight.
Yes. But if you are in Ohio and would, again, like to have coffee, lunch, or a cocktail, please reach out, and I will make sure
Give us a shout.
Come
to the run. It's on Sunday, this coming Sunday, in Ohio at Ohio State University.
Yeah. And then, obviously, a huge thank you to Genentech for making all of this possible. Without funding from partners like them, we wouldn't be able to do any of this. Well, we could do it at my house, but we wouldn't be able to do any of this. So a huge thank you to Genentech, obviously to Penn TV, who you guys are getting to know really well. If you haven't met the crew, introduce yourself, because they're great. We always have have an interesting time coming here, and I'm going to tell a little insider secret about my mom's adorable dog that I know most of you have met. And she will blame it on my sister's adorable dog, but every time before our living room, we always have to come in here and make sure there's no surprises laying around, because the dogs love to come in this room. And so the guys sometimes are like, Danielle, and I'm like, because I missed it.
My dog is perfect.
Yes,
It's
of course,
not
her
my
dog is perfect. Yes. So thank you again to Penn TV and all that you do for us, Genentech, and of course to all of you. And with that, we will see. Oh, next April. Oh yeah, I have these for you guys. I want to show you. I was going to pass them out on the way out, but this is a program that we put together about some of our affiliates. You will recognize some of the people in here, and just some of that. We wanted to acknowledge some of the great things that they've done for us, and it's a really cool little piece. So I want to make sure that everybody gets a look and can see what some really great and novel ideas, the things people are doing to help support lung cancer patients and the cause. So it's really great. And now you made me forget what I was going to say.
Can I say something before Jeff?
I'm going to let you say something. April, yes, thank you for bringing me back to where I was. Yes, I just want to remind everybody, next month, April's meeting will be patient roundtable, so we will not have a speaker, which means we will all get more time to talk about ourselves and how much we all like to do that. So that's April. And then May, we have Dr. Paul Billings coming to talk about next-gen sequencing, what that kind of looks like for the future. And now I'm going to let you speak.
Okay, the only thing I have to say is that you, all of you, or your families have the key to the solution to unlock the code to cure lung cancer in your bodies. And I'm going to give a shout out to all the pharmas out there and the biotech companies and so on and so forth. And there's one in the room tonight, so here's a challenge for Clovis. When you find the drug, and it's in the newspapers, and it's rah, isn't this great? We have a new drug for lung cancer. I want to see a big thank you to the patients that participated in the clinical trials to get that drug to market. Because what we always see is new drug, pharmaceutical company that created it, but really, you all did it. Without you, it wouldn't be happening. So thank you. Jeff?
That's it from I have no sign-off particular at the end. I mean, I guess one project we want to talk about is that we're moving on to next is a unique population with lung cancer that's not really been studied very well. And that's if you're young and you have lung cancer under age 40. We don't understand why that happens, and we're trying to figure that out. And so just know that there is a new effort starting here, and please contact us if you want to be included, and we'd love to help try to figure out why that happens.
So that's it. Thanks for
everyone.
another great night, guys.